Hello guys, welcome back to A to Z Dentistry, a channel which features easy explanation of various medical and dental related topic. And our today's topic is cracked tooth syndrome. So without any further delay, let's get started. So today we will be discussing cracked tooth syndrome under the following headings: synonyms, definition, etiology, clinical features, diagnosis and management. So let's begin with discussing the synonyms for cracked tooth syndrome, right? So the first and most commonly used synonym is crown originating fracture, right? Now this synonym is given because the fracture line usually originates from the crown of the tooth, right? So here you can see this is the fracture line involving crown of the tooth and then it is going downwards, right? However, this is not a complete fracture, right? It is not encompassing to complete tooth, right? It is only up till the middle 2/3. The apical 1/3 is spared, right? Therefore it is also known as incomplete tooth fracture. And because the tooth is completely split into two parts, here you can see from the cusp the tooth is completely split into two parts, therefore it is also known as split tooth or cracked cusp syndrome, right? The cusp is completely cracked, so it is also known as cracked cusp syndrome. So we have four synonyms for cracked tooth syndrome. The most common one being COF, that is crown originating fractures. Then we have incomplete tooth fracture, split tooth, as well as a cracked cusp syndrome. Moving on towards the definition for cracked tooth syndrome, it is defined as an incomplete fracture of the tooth with a vital pulp. This line is very important, right? First of all, it is an incomplete tooth fracture, and second is the vitality of the pulp remains intact, right? We have a vital pulp, therefore pain is a chief complaint in such cases. Why? Because the vitality of the pulp is still intact, and whenever we know that the pulp is vital, definitely it will cause pain, right? So an incomplete fracture with a vital pulp, which means pain. Patient will complain of pain, right? This fracture involves enamel, dentine as well as the underlying pulp. Okay. Moving on towards the etiology for cracked tooth syndrome, right? So etiology can be broadly divided into two parts, that is natural predisposing features as well as iatrogenic causes. So iatrogenic causes are the causes which occur as a direct result of any dental treatment, right? Let's suppose you are treating a patient for a particular dental condition, and due to use of certain instrument there is induction of micro cracks within the tooth, right? So such causes are grouped under iatrogenic causes. So let's discuss each of them broadly. So first, under natural predisposing features, we have the occlusal anatomy, right? So under occlusal anatomy, we can think of a high cuspal stresses, right? So there are certain teeth, especially the posterior teeth, which might have sharp cusps, right? Now these sharp cusps are areas of concentrated biting forces, right? So here let's suppose this molar, right? So this molar has a very high cusp, right? Very sharp cusp, and due to which there is continuous amount of stress on the lower teeth, right? So over time, because of these forces, there is weakening of the enamel and it might lead to small micro fractures, especially in the cuspal area of lower teeth, right? So what will happen, this sharp cusp will lodge here, right? And this can cause micro cracks within the lower teeth. Second factor under occlusal anatomy would be presence of any deep grooves or fissures, right? Right now these deep grooves basically act as stress concentrators. Okay, so when a force is applied during chewing or during grinding of the food, these areas are more prone to microcrack formation, right? And because of this there might be a fracture. or a crack within the tooth. Second is presence of any malocclusion or uneven biting forces. So let's suppose the teeth are not aligned in a certain fashion, right? There is a pathological occlusion which is occurring, right? And therefore there are excessive amount of biting forces which are delivered onto the tooth. Then this can result in formation of micro cracks, right? So these three factors are included under occlusal anatomy, right? The first one being high cuspal stress, right? Second is presence of any deep grooves or fissures, and the third one is malocclusion. Third one is malocclusion. Now moving on towards bruxism or presence of any parafunctional habits, right? Now in bruxism we know that there are exaggerated occlusal forces, right? Now teeth with this exaggerated occlusal anatomy may experience even a greater stresses, right? For example, a patient is continuously grinding his teeth, right? Which happens in cases of bruxism, grinding on clenching of the teeth. Then because of the continuous amount of forces which are delivered, right, this can make teeth more likely to crack, right? So bruxism is another very important cause of cracked tooth syndrome. Then another cause which we can include are weakened structure from presence of any underlying restorations, right? So whenever a teeth is already compromised and we have treated that teeth with the help of certain restorations or fillings, right, and these fillings are suppose not underlined properly, these are not done properly by any clinician, so that there is a disturbance in the occlusal anatomy, right? So when a restoration might be overfilled or it might be underfilled, right? So in both these cases there will be abnormal amounts of occlusal load which are delivered onto the tooth, and this can ultimately result in formation of cracks within the tooth. And the last predisposing factor would be aging, right? Would be aging. Now as we age, right, what happens is their tooth undergoes wear and tear, right? There is simultaneous wear and tear which is occurring, and these weakened areas which are formed within the tooth have an increased susceptibility to formation of cracks, right? So when there is significant amount of wear which is present onto the teeth might not be able to counterattack the amount of occlusal forces which are delivered, ultimately resulting in formation of cracks. Moving on further towards the iatrogenic causes, right? Now under this, first we can study is regarding procedures which are frequently used in restorative dentistry, right? So in cases of restoration, particularly class 2 restoration, we use matrix bands, right? So over tightening of these matrix bands or clamps for that matter can lead to formation of micro cracks. Then improper carving as well as ill fitted fillings, right? The fillings which are not in harmony with the occlusal anatomy can lead to formation of micro cracks, right? Then the second would be cementation. During the process of cementation for of a crown, for example, if at all the clinician applies excessive pressure, it can lead to a spontaneous crack formation within the tooth, right? Then excessive tooth reduction. Suppose you are preparing a tooth, okay, and there is an aggressive removal of enamel and dentine in order to prepare for an inlay and onlay, right? This might compromise the integrity of the tooth. Here you can see there is tooth preparation which is depicted, and if at all you are doing it very aggressively, what can happen? There will be removal of enamel and dentine, right? This can compromise the integrity of this particular tooth. So whenever there are even normal amount of occlusal forces, this tooth will not be able to adjust to that because it has a weakened structure and therefore it will lead to formation of micro cracks, okay. Another would be endodontic over preparation. Now excessive canal shaping or excessive removal of the dentinal walls during the RC treatment weakens the tooth, and therefore it naturally predisposes the tooth to cracking or towards formation of micro cracks, right? Apart from this, consider a scenario during extraction, right? So during extraction, if at all the surgeon applies very excessive amount of forces or uses any incorrect technique, right, then the adjacent teeth can bear the burnt of this, right, leading to formation of cracks. So these are certain causes which are included under iatrogenic causes. Now let's discuss about the clinical features of cracked tooth syndrome. So our first subheading would be prevalence, right? So the teeth which are most commonly involved in cracked tooth syndrome are the mandibular molars, right? So as discussed previously, if at all there is a very sharp lingual cusp, it can progressively weaken the structure of the lower molar, right? Making it more prone to cracked tooth syndrome. Okay. So our first tooth which is most commonly affected in cracked tooth syndrome would be mandibular molars. These are then followed by maxillary molars and maxillary premolars, right? So here you can see mandibular molar, right? It is completely fractured here, you can see. So this is the most common tooth which is involved in cracked tooth syndrome. So this might be directly asked as an MCQ question. So you must remember, most commonly the tooth which is affected are the mandibular molars, and least common would be maxillary premolars. Apart from this, molars of older individual are more frequently involved in cracked tooth syndrome. Now why this is the case? This is so because, as we have discussed previously under causes, we have discussed about aging, right? So what happens with aging? There is increase in the wear and tear. There is increase attrition, right? There is increase in the attrition. Now because of this attrition, there is progressive weakening. There is progressive weakening, and there is increased susceptibility for fracture, right? So molars of older individuals are affected more frequently. So let's focus here. Here in this tooth, you can see this is the fracture line, right? And this is highlighted with the help of a dye. Now this dye is nothing but methylene blue, right? Methylene blue is a very common dye which is used to delineate the line of fracture. And here you can see this is the fracture. On the occlusal surface, you can very well appreciate the attrition, right? This is attrition which has occurred, and due to this compromised tooth structure, there is formation of these cracks onto the surface of the tooth. So hence molars of older individuals are more commonly affected. Towards the clinical features for cracked tooth syndrome, right? So we'll be discussing under prevalence. So this cracked tooth syndrome occurs mostly in teeth with class 1 restoration, right? That is about in 39% of the cases, or in cases of unrestored teeth, right? But in cases of class 1 restoration, this is very prominent, right? In most of the cases, it will occur in cases of class 1 restorations. There is an important factor in this which I have to mention, that is, in cases of unrestored teeth, it can occur. Why? Because there is something known as a plunger cusp, right? So what is this plunger cusp? Basically these are the cusps that tend to forcibly wedge the food into the embrasure area, right? Into the embrasure area of opposing teeth, right? So for example, we have maxillary first molar, right, which has a plunger cusp, and it will forcibly wedge the food in between lower first and second molar, right? So these are known as plunger cusps, basically the cusps which tend to forcibly lodge the food into the embrasure area of the opposing teeth, right? Now these plunger cusps can also occlude centrically against the marginal ridge and cause cracked tooth in the opposing dentition, right? So in most of the cases, definitely yes, class 1 restoration, and the second most common teeth are unrestored teeth, usually which have a plunger cusps opposing to them. So in this figure we can see, right, here you can see this is a case of class 1 filling which is done here, right, in case of second molar. And if at all there is an opposing tooth in the maxillary arch, what it can do, it can forcibly wedge the food over here, right? And it can cause spontaneous cracked tooth syndrome. Again, in this figure we can appreciate there is a formation of a crack, right? Now once we remove this kind of feelings, right, if the patient suppose complains of pain to you, examine a scenario wherein you are seeing a patient who is continuously complaining regarding pain, however you do not see any faulty restoration, right, nor there is any periapical lesion. Now you might suspect what is the cause of this pain, right? So it can be because of presence of cracked tooth, and because of this huge feeling you may not be able to see or point out the fault, right? That is what is causing the pain here. But in such cases you can definitely suspect a cracked tooth syndrome, and once you remove the filling you can clearly appreciate the crack, right, which is present here, right? This is the crack, right? So in most of the cases, yeah, you need to remove the filling and then check for any cracks onto the surface of tooth. Let's discuss about the symptoms, right? So patients typically report of a sharp pain while chewing, especially after the release of the bite, right? So this can be a very important distinguishing feature, right, to distinguish cracked tooth syndrome from other pathologies, right? There is a sharp pain while chewing, and this is more prominent after the release of bite, right? Then definitely sensitivity to hot, cold or sweet foods will be there, right, because the pulp is getting involved and the pulp is vital, right? So definitely sensitivity to hot, cold and sweet foods would be there. Then pain that is intermittent in nature. What is the nature of pain here? It is intermittent in nature and hard to localize, right? Sometimes clinically you might not see presence of any crack onto the occlusal surface, right? You might not see any crack, but once you see that particular tooth under magnification or after application of dyes such as methylene blue, you will be able to visualize the crack correctly, right? So it is very important that when you are getting a patient who is reporting with a sharp pain, especially after release of bite, right, and which is hard to localize, intermittent in nature, and obviously you cannot find any obvious pathological anomaly within the tooth, so you can go for illumination test, magnification test or application of methylene blue, so that you will be able to see the cracks if at all it is present. Moving on further, now once we have seen the clinical features, now we need to arrive at a proper diagnosis, right? We need to make sure that we are arriving at a correct diagnosis. So for that, our first tool would be visual examination, right? So close examination of the crown, right? And after a close examination, might be in some cases you will be able to see an enamel crack, right? But in most of the cases you won't be able to appreciate these micro cracks. So for that we have some other tools, right? The first one is use of a fiber optic light, right? So this is used to trans illuminate the line of fracture, and most of the cracks run mesodistally, right? And they are very difficult to detect radiographically, especially when they are incomplete, right? So here we are talking about a crack which is restricted onto the mostly the crown part of the tooth, right? It is not going all the way till the root, and in some cases not even a single fracture line, but there could be minor micro cracks which are present, right? So in such cases fiber optic light is a very important tool, right? And with the help of this trans illumination we can appreciate the fracture line. Apart from fiber optic light, we can also make use of a dye, right? As I have mentioned previously, methylene dye, that is methylene blue dye, is very important tool which comes handy to a dentist, right? So you need to dry the tooth properly, right? You need to dry the tooth, then you can apply the dye, wait for about 2 minutes or so, and then clean the dye, and you will see that suppose this is the occlusal surface, right, and this is your crack, and after application of dye what will happen, this crack will retain the methylene dye, right? It will retain the dye, and thus you can clearly see the line of fracture. You can see the fracture line, right? So this dye is a very good alternative when you are not having fiber optic light with you, and therefore it is a very important tool to diagnose cracked tooth syndrome. Yeah, so this is a diagram which is depicting use of fibro optic light, right? So what we are doing, we are doing a trans illumination test. So you can see clinically this tooth appears absolutely healthy, right? But when you see it under the trans illumination or the fiber optic light, you can appreciate the crack, right? It is here, it is very minute, but yes, it is definitely present. So this light is very important tool which can help you to differentiate cracked tooth syndrome from other pathologies. Our next test was the dye test, right? So on the dye test, this is methylene blue dye test, right? Very important test. So here you can see there was a filling which was done over here, an amalgam filling was done, right? And this is the line of fracture, right? This is the crack, this is the crack. Can you appreciate the extension of this fracture line, right? So after application of this methylene blue dye, you can see the fracture line appears very clearly to the clinician, right? So this test is also very important as far as diagnosis of the cracked tooth syndrome is concerned, right? So the first is transillumination test and second is the dye test. Our next test is bite test, right? So it is a very important step in clinical examinations, right? Why? Because this is almost a definitive and a chair side test to diagnose cracked tooth syndrome, right? So this is done with the help of a moist cotton roll or by using a tooth slot, right? This tooth slot is a device which is used for conducting our bite test. Moist cotton roll is rarely used, right? So you need to know about the tooth slot. So basically this is a small pyramidal shaped plastic bite block and it has a small concavity at the apex of the pyramid, right? So this concavity is basically present to accommodate the tooth cusp, right? The small indentation is placed onto the cusp and the patient is then asked to bite down, right? Thus the occlusal force is directed to one cusp at a time and this exerts the desired pressure onto the questionable cusp, right? So we'll place the tooth slot, right? It will accommodate the cusp of the tooth, right? And then we ask the patient to bite down, and as the occlusal force is directed to a single cusp at a given point of time, thus it exerts the desired pressure which we require to diagnose the cusp in question, right? So this is a diagram of the tooth slot, right? So this is the device which is useful for diagnosis of cracked tooth syndrome. Here you can see how this test is carried out clinically. The concavity, right? The concavity on the surface of the pyramid is placed onto the suspected cusp and we ask the patient to bite down. See, this is how it is placed, the concave area on the cusp, right? And then we ask the patient to bite down, right? And then if at all the patient complains of pain, then definitely you can say it is a case of cracked tooth syndrome. Likewise, if the patient bites down and then the patient doesn't complain of any pain, right? So then you can say that this might not be a case of cracked tooth syndrome and then you have to look for other pathology with that tooth. Again here on this page, right, we are saying some other techniques which are used for diagnosis of cracked tooth syndrome. First one is again transillumination, which we have seen by use of fiber optic light, right? So here you can see clinically if at all there is no crack whatsoever present, but once you are using this fiber optic light, you can definitely appreciate the crack, right? You can definitely appreciate the crack which is present in this region. See, the arrows are pointing towards the crack. Okay, so transillumination very helpful. Then via magnification also you can identify such cases, right? So there are microscopes which are available, right? And with the use of these microscopes you can see the structure of the tooth more clearly and hence you will be able to delineate the fractured tooth. Also radiographs are a way to diagnose this syndrome, but in most of the cases there are micro cracks, right? So these micro cracks are not readily visible on the radiograph, but if at all the fracture line is very prominent, and if at all it is extending and covering a large surface area of the crown of the tooth, then you might be able to appreciate the fracture line on the radiograph as well, right? So here they have taken a cross section and you can see the line of fracture, right? The arrows are pointing towards the line of fracture. So again, three ways: transillumination, magnification, and use of radiographs. Moving on towards the treatment part or the management part. So I have divided into two types, right? First one being the general management, right, and the other would be definitive management in such cases. So the treatments which are very commonly employed for cracked tooth syndrome include occlusal adjustments. Definitely if you encounter any plunger cusp or a sharp cusp for that matter, which is impinging onto the opposing tooth and harming the tooth, then definitely occlusal adjustment is a very important step which needs to be undertaken. It will relieve the stress onto the tooth and will prevent further damage to the tooth, right? Second is by direct restorations like composite fillings. If at all there are minor cracks which are present, right, if minor cracks are present, you can just remove the filling, right, and then you can ask the patient to undergo composite restorations, right? Then third would be providing a full coverage crown. So the full coverage crown will basically cover the entire surface of the crown, and therefore it will prevent further cracking of the crown as well, right? In addition to this, we have root canal treatment if the pulp is involved, right? So root canal treatment can also be done, and in some cases, if at all the condition is such that any preventive measures will not help the patient much, then the last option would be extraction. In severe cases, if the crack is extending till the middle third of the root portion of the tooth and the tooth is not salvageable, then definitely in such patients extraction is the modality of the treatment which needs to be used by the clinician. Moving on towards the definitive management, right? So if the initial pulpal diagnosis is reversible pulpitis, right, based on the symptoms which are given by the patient, and in case of reversible pulpitis, what are the symptoms which the patient will tell you? First would be there would be absence of any lingering pain to hot and cold, right? Particularly to cold, there will be no spontaneous pain or any severe pain, right? So in such cases, you need to wait for a 2 week period, right? Waiting period for 2 weeks is recommended. The tooth is then stabilized with the help of an orthodontic band for these 2 weeks, right? This is one line of treatment. If the initial diagnosis is reversible pulpitis, then the definite treatment of a cracked tooth will basically attempt to reverse the vitality of the pulp, right? And this will definitely require a full coverage restoration. An occlusal cusp or a full crown will be required so that the tooth is stabilized and there is no further harm to the tooth as well, right? And if the patient has an incomplete fracture which is only involving enamel and dentine, then a full crown restoration will be helpful. So guys, that was all about cracked tooth syndrome. I hope you understood the topic very well. I will be back with a new video very soon. If you like the video, kindly consider subscribing to my channel. Till then, this is Dr. Snehal signing off. Bye bye, take care.